Dr. Wayne Batchelor is the Director of Interventional Cardiology and Associate Director of Innova's Heart and Vascular Institute in Fairfax, Virginia. He also serves as a professor of medicine at Duke University, chair of the American College of Cardiology's Interventional Sectional Leadership Council, and co-chair of the U.S. National Transcatheter Valve Therapy Registry. Dr. Batchelor's clinical and research interests include complex high-risk percutaneous coronary intervention, cardiogenic shock, structural heart disease, and healthcare disparities. He has published over 200 peer-reviewed original abstracts, manuscripts, multiple book chapters, participated in over 160 clinical trials, including serving on several national, international clinical trial steering committees and national principal investigator of multiple clinical trials. Dr. Batchelor was instrumental in designing and co-leading the Platinum Diversity Study, the world's first study to prospectively evaluate coronary stent outcomes in women and underserved minorities. He currently serves on the editorial board of Circulation, the Journal of the Society of Cardiovascular Angiography and Interventions, and Cardiovascular Revascularization Medicine. He's a frequent guest editor for the Journal of the American College of Cardiology, and a special government employee and consultant to the U.S. Food and Drug Administration within the cardiovascular devices branch, with an interest in improving patient diversity in clinical trials. Dr. Batchelor is currently pursuing an executive MBA from New York University after receiving NYU's Diversity in Business Scholarship. He enjoys traveling and spending time with his family. In addition, I just found out, for example, that he was also one of the first recipients of our Harry Jerome Award here in Canada. So it gives me great pleasure to welcome Dr. Wayne Batchelor. Over to you, sir.
Thank you so much, Anthony. First of all, can you all hear me okay?
Perfect.
Yes, we could. Perfect.
So lots of connections that we could talk about to Canada, to Jamaica, to Toronto, Kingston, Ontario. You know, I went to Queens. I was born in Kingston, Jamaica, and my family immigrated to Kingston, Ontario, Canada when I was 1 year old. So really, I consider myself Canadian and American and also Jamaican. So I really am enthusiastic and impressed with the organizations that have presented before me. Congratulations to all the work that you're doing. And this Heritage to Health virtual workshop is just a testimonial to the really incredible work that you're doing north of the border here. I apologize, I was a bit tardy, but I'm actually at another meeting. I had to race home from a meeting at the American College of Cardiology. I live in Northern Virginia, and I had to get through traffic and get here. And I left that meeting, honestly, to come and present at this. I'm still supposed to be there, but luckily I'm not presenting. So I told them I was going to cut that one short because I think this is extremely important. And the topic that we're going to talk about is, no pun intended, very near and dear to my heart. But understanding just some basic principles of heart disease prevention and understanding at the end of the day what we all can do as children of the Black African diaspora across the entire world to lower our risk, because unfortunately we are at higher risk. So over the next few minutes, and I'll try to take maybe 25, 30 minutes for my presentation, I do want to leave some time to open up some discussion and questions. I noticed that there are some other speakers that are probably more able to address some of these topics than I, but I'll try to touch on the salient ones and try to give you at least a smattering of what I consider are the key elements to understanding heart disease risk. Cardiovascular disease is the #1 cause of death in the world. It overtook infectious diseases a couple of decades ago. And right now, at any point in time, there are about 423 million people in the world suffering from some form of cardiovascular disease. On the right of this slide, you can see the global distribution of cardiovascular disease. And this is graded according to daily adjusted life years affected. So this takes into account not only the prevalence, but also how much this has impacted the life of the patients who are afflicted by heart disease. You can see that parts of Europe, obviously Russia, sub-Saharan Africa, and tend to be disproportionately affected by this condition when you take into account quality adjusted life years and daily adjusted life years. United States and Canada, you can see, are actually less afflicted, but still, this is the #1 cause of death and disability in the United States. And actually, cancer is the #1 cause in Canada, interestingly, with heart disease following very soon thereafter. I know that this might be simplistic, but I did want to make sure that we're all on the same page before we embark on some other discussions about heart disease, because the terminology here is important, and there's some simple anatomic realities that we need to understand for us to embark on a well-informed discussion about heart disease prevention. This is just a cross-section, a cartoon of the heart. As you probably know, on the right side, the blue blood is blood coming back from the body in the venous system. It empties into the right atrium and right ventricle. It's pumped to the lungs, comes back, and then to the left side of the body, the left ventricle and aorta carry body to the rest of the body. Oxygenated blood that comes back from the lungs. Simplistic, but important to understand, because the heart is basically a simple pump. And for each of those heartbeats to be generated, there has to be an electrical input created. So there's an electrical aspect of the heart that generates the myocardial contraction, the heart contraction. And then there is heart function. and then we have to make sure that the blood's going the right direction. So there are multiple valves in the heart to ensure the blood's flowing freely through the circulatory system in the right direction. And so most importantly, not shown on this diagram are actually coronary arteries, the arteries that supply this extremely vital organ with oxygen and nutrients. And those are the coronary arteries. And coronary artery disease, blockage, plaque, cholesterol deposit, and blood clotting in these vessels is actually the #1 aspect and killer of patients who have cardiovascular disease. So by definition, heart disease is any disease of the heart, the blood vessels, any disturbance of rhythm, in some cases, sudden stoppage of the heart rhythm, which is called sudden cardiac death, usually due to ventricular fibrillation. And you probably have heard many athletes over the last number of decades have actually suffered from various forms of heart rhythm disturbances. NFL football players, basketball players, due to underlying abnormalities of usually the heart muscle. And then the most common cause is what I mentioned, is atherosclerosis of the arteries. Coronary atherosclerosis is shown here in a cartoon fashion. You can see in the very top right, there's a healthy artery. These arteries are the arteries here that lay on top of the heart that supply blood to the heart. Without blood and nutrients, the heart can get damaged, can stop pumping effectively, and can develop rhythm disturbances. So when you're born, this is what your artery looks like. As you get older, unfortunately, this is what can often happen. The yellow material here is plaque building up on the wall of the artery. This encroaches on the blood carrying capacity of the vessel. And when clot forms on top of this, sometimes abruptly, this is what can really be devastating for patients. In most cases, this may present just as some simple chest discomfort on exertion, but in some cases, it can present as sudden cardiac death, especially if this artery suddenly blocks off. And if we understood exactly why patients can have some plaque in their vessels, not know it, and then why at some point in time, some patients suddenly develop a blood clot on top of that plaque that leads to death, that would be a Nobel Prize in medicine. We really don't understand what induces what we call plaque rupture, which is usually the inciting event to an episode of cardiac death. So there's lots to be learned, but what we do know are the risk factors for developing this fatty cholesterol-laden deposit in the blood vessels of the heart that causes so much death and unnecessary debilitation to patients in North America. This is a cross-section of that artery. On the left, you can see there's a wall of the artery that's a muscular wall. The blood is carried in the central part or the lumen of the artery, but in the wall, this plaque develops. And for some reason, and we don't understand why, sometimes that plaque ruptures, and then there's a clot that forms suddenly. And that is what can be devastating. On the right, that can lead to unstable symptoms. And on the right, this is more of a stable situation where a patient might present with more predictable symptoms, such as chest discomfort, what we call angina, particularly on exertion, often relieved by rest. Now, there's a burden of atherosclerosis, which is that plaque deposition that can occur anywhere in the body from head to toe. If it occurs in the blood vessels leading to the brain or in the brain, that can lead to a stroke. If it occurs in the arteries of the heart, that can lead to a heart attack. And if the blood vessels dilate, either in the chest aorta or in the aorta in the abdominal section, that can lead to an aneurysm, which can burst and lead to sudden death. And then, of course, lower extremity plaque can cause unnecessary amputations and pain in the legs when walking, called claudication. It's important to note that Blacks in general are at higher risk of all these forms of atherosclerosis and also suffer more significantly in terms of the degree of impairment that results from either a stroke, a heart attack, or lower extremity disease. In fact, amputations are about twice as common in Blacks versus whites, partly due to extent of disease, but largely due to access to healthcare, recognition of symptoms, and early treatment, which is the key. I know that the Walnut Foundation forms its basis for its preventive approach to encourage Black men to get their screening done early, but also heart disease is much better dealt with when caught early. And we'll get into a few things that we can do to ensure that we recognize if we have heart disease, even if we're asymptomatic. Now, the epidemiology of heart disease in Canada is pretty significant. I was surprised to dig up some facts and find out that actually cancer, for the first time in a while, has taken over heart disease. Worldwide, heart disease is still the #1 killer in the world. In the United States, heart disease is the #1 killer. But interestingly, in Canada, cancer slightly has outpaced heart disease in terms of the number of Canadians dying per year. But still, there are about 2.6 million adult Canadians who live with heart disease. That's about 1 in 12. Every hour, there are about 14 adults who are diagnosed with heart disease and are die from heart disease. The death rate is higher in men compared to women, slightly. But interestingly, postmenopausal, once women go through menopause, there's no difference in the incidence and prevalence of heart disease. So there's a catch-up phenomenon, perhaps some preventive aspect of female hormones in slowing the progression of heart disease or preventing it. But there's a significant catch-up in women. In the United States, heart disease is still the #1 cause of death. And in Canada, it's still #2 cause of death. So a very, very important epidemiologic problem that afflicts the entire world, and Canada, unfortunately, is not spared. Now, Canada is getting older, as you know, are most developed countries, and we see here that the population of those aged 65 and older is going to basically double in the next several decades. This is going to have a tremendous impact on a number of health-related factors. #1, patients who are older have obviously higher rates of heart disease, but also higher rates of other degenerative conditions, cancer, osteoarthritis, hospitalization, and they also consume a lot of healthcare dollars. So this has a lot of economic implications, particularly when we superimpose this interesting graph, which shows the labor force in Canada out to 2068. And you can see here that their labor force is dropping significantly, and we're seeing more old patients, a huge bolus of older patients coming into the system. So strap on your seatbelt, because both Canada and the United States are going to be faced with tremendous stressors on healthcare systems that are largely reliant on tax revenue in order to fund these systems. and take care of our older patients and our patients in general. So a lot of challenge facing all healthcare systems in the next couple of decades. Now, in terms of risk factors for cardiovascular disease, these are the ones that you really should know about, but there's some emerging risk factors that we can hopefully talk about in the discussion section. First of all, age is perhaps the number one risk factor, but as we go clockwise around this circle, blood pressure, smoking, diabetes, physical inactivity, overweight state, obesity, high cholesterol, those in green are modifiable. Luckily, the majority of risk factors are modifiable. It's estimated that somewhere between 70 to 85% of your risk is in your hands. Very important message to take home. If you dealt with all of the things on the right side of this diagram in green, you could reduce your risk by at least 70%, and some feel upwards of 80%. Not modifiable age, although some may argue that your actual chronologic age is not modifiable. How fast your vessels age is probably modifiable. Gender, what really is your sex, genetic factors, race, and ethnicity have been considered not as obviously modifiable as the green factors. So just something to keep in mind. And there's a few other risk factors that relate to Blacks who live in any country that has especially systemic racism. There's some really fascinating epigenetic risk factor data coming out suggesting that when Blacks are exposed to high stress situations, and we unfortunately are more commonly exposed to underlying chronic stress, there is this interaction between your genetic predisposition and that stress that probably is an additional risk factor. There's some fascinating data tracking stress hormones according to race and ethnicity, and linking that to systemic racism and exposure to that, in addition to socioeconomic factors that probably add to the risk of both heart disease and cancer. Really fascinating data, but some emerging data to suggest that where you live, how you live, and what kind of underlying stresses you face may impact your incidence and prevalence of these important diseases. So how can you reduce your cardiovascular risk? This is a really important calculator. I would encourage you to take a screenshot and consider going to this particular calculator and plugging in your numbers. Everyone should understand their blood pressure, both systolic and diastolic, their cholesterol, both total HDL, which is good cholesterol, and LDL, which is the bad cholesterol. And with those simple factors and plugging in your age, your sex, and a few other factors, you can come up with your 10-year risk of having a heart attack or stroke. And if you're younger than 40, they give you actually a 30-year risk. And if your risk in that calculator is above 20%, you're considered to be high risk. If you have a 20% risk of having a heart attack or stroke in the next 10 years, intermediate risk is 5 to just under 20%, and low risk is under 5%. What you'd like to do is try to get yourself into the lowest risk category and speak to your physician or healthcare provider about what your risk is. I would challenge you to go into your next office visit with your numbers. And if your numbers are in the intermediate or high risk, talk to your doctor about what you can do to understand your risk further and also how to lower that risk. Very important. This is empowering. And this is what Black people need to do across the world, is take into account and into our own hands our healthcare, so that when we get that little 15-minute snippet of time that the primary care doctor nowadays is affording you, you're armed with the right questions. This is a great question that could impact your life. So how do we reduce risks? Obviously, smoking is very important. If you smoke, you're doubling your risk of cardiovascular disease. The good news is if you stop smoking, it actually normalizes about a year after that. Whatever lung disease you're left with, you're left with. What's fascinating is the inflammatory aspects of smoking on your heart arteries tends to settle down when you stop. So it's never too late to stop smoking. And we're going to get a lot more information about vaping and other forms of nicotine ingestion. The challenge is we just don't have the long-term studies, but I can tell you my prediction is we're going to see all the ill health effects. We're seeing them now, but we're going to see them even greater in the next 10 to 20 years as all these vaping patients enter the system later with problems related to chronic nicotine use. Blood pressure, just some simple elements of blood pressure that we can discuss. A normal blood pressure is 120/80. That's the number that you need to understand. It used to be 130/80, 130/85. And we're realizing now that there's a continued risk in the folks that are sort of elevated slightly at over 120 or over 80. 120 is the top number, 80 is the bottom number. Measure this at home with a blood pressure cuff that goes on your upper arm, not on your wrist, in a resting, relaxed state. Your blood pressure goes up with anxiety, with emotional upset, with physical activity. Don't get off the treadmill and measure your blood pressure. Don't get in an argument with your family or friends or whomever and then measure your blood pressure. If you're vexed, get on Vex, rest, relax, and measure your blood pressure after that, okay? Very important because there's a real element called white coat syndrome. I see it all the time. Patients are at home and their blood pressure is 118/75, and they come in and they see the white coat or they're in the office and their blood pressure is 150/95. Happens all the time. What's more predictive is your blood pressure at home, at rest, taken with a blood pressure cuff that fits appropriately in the upper arm. That is what we should use to measure our blood pressure. And it's the average blood pressure, not one reading. So very important. If you go into your doctor's office and you tend to have a little pressure issue, measure your blood pressure at home. Some in the morning, some in the evening, several days a week, daily if you can, and create a log and go in with that log and present that log to your family, to your provider, and then they'll have an accurate assessment of your true risk. There are cases of undertreatment of blood pressure, and there are cases of overtreatment sometimes relative to just not understanding what the pressure is. Why is this important? Because there's a direct relationship between your blood pressure and your risk of cardiovascular disease. This is an older paper that just shows even if your blood pressure is normal, so-called normal in the 130/80, what used to be normal, your risk is higher than if you're in the optimal range. Now, there are some patients who just can't get down below 120/80, especially as you get older, because they get lightheaded or they have side effects, but there should be an effort to try to get to those numbers, if at all possible. And there are lots of different strategies to accomplish that. And most of the things that I'm talking about today will not only reduce your risk of cardiovascular disease, heart attack, and stroke, it'll often improve your blood pressure and your cholesterol. Diet. I'm not an expert in diet, but there's some basics that we all need to understand. It's been proven time and time again that there's a gradient of cardiovascular risk that relates to what you eat. And this actually has been proven in multiple observational studies. Probably the healthiest diet you could consume is a vegan or vegetarian-based diet. I think that's actually pretty clear. It's just that it's very hard for a lot of people to adhere to a pure vegetarian or vegan diet. So if you engage in a diet that's just rich in unsaturated fats, low in trans fats and saturated fats, lots of whole grains, lots of fiber, fruit and vegetables, a colorful array of vegetables, and that's low in cholesterol and animal fat, then you're probably doing the right thing. That could be the DASH diet or the Mediterranean diet. We have these diet fads where people use all these diets to try to lose weight, but you got to pick something that's going to stand the test of time, something that's backed up by clinical data, and that's something that doesn't disrupt the rest of your metabolism too much. So the DASH diet and the Mediterranean diet or a vegan diet are my favorite diets. And I think there's solid data that these diets are associated with lower cardiovascular risk. So if you want a little bit more information about diet, ask your provider if you can speak to a dietitian and really go over your daily consumption of what your intake is and how you can perhaps adjust this in a healthy fashion. Cholesterol. Cholesterol is a problem. About 40% of Canadians have some form of high cholesterol. And there's very good data that I could show you the same graphs relating cholesterol to cardiovascular risk as we did with hypertension. But suffice it to say that there's good cholesterol, there's bad cholesterol, and then there are triglycerides. HDL is considered your good cholesterol. We want that value higher. HDL is actually a lipoprotein molecule that packages bad cholesterol and good cholesterol and takes it usually from blood vessels back to the liver where it's metabolized. So it's kind of like a waste basket that collects cholesterol and helps reduce the level of cholesterol in blood vessels and tissues and takes it back to the liver where it can be metabolized. LDL is the opposite. LDL is where your bad cholesterol is carried often from the liver into the circulation and into the blood vessels. What most of us don't really understand and realize is that the cholesterol in your body that's circulating, 80% of it comes from your liver. It's manufactured in your liver. Some of that's genetic, some of that's dietary. Unfortunately, a lot of it's genetic. So, when we say, we have patients who come in and their good cholesterol is low, their bad cholesterol is high, and they're doing all the right things. Unfortunately, that is not something that's easy to change without medications. And even the best diet and exercise and weight control sometimes leaves patients at incremental risk thanks to their genetics. So understand your cholesterol, understand what your total number is, your good cholesterol, the HDL, and your bad cholesterol, the LDL, and your triglycerides. Have discussions with your primary care provider as to whether or not your levels overall are good and the fractions of those various components are appropriately controlled. Exercise. Very simple prescription for exercise. Exercise can help prevent diabetes, control weight, lower cholesterol, and lower cardiovascular disease risk, as well as some evidence that it cannot lower your risk of cancer in some conditions. So it's a really simple way for us to improve our health. The recommendations from the American Heart Association, this is similar across multiple countries, Europe, Canada, is at least 30 minutes of moderate intensity activity at least 5 days a week for a total of 150 minutes. What does that mean? Walking your dog briskly or walking briskly would suffice. Swimming, light biking. Now you can go less in terms of what's required for benefit if you up the vigor with which you exercise. So light jogging, for example, and more significant things like playing basketball, swimming more aggressively, riding a bike more aggressively. If you just get 25 minutes 3 days a week, you're probably doing enough to impact your cardiovascular system and lower risk. This is particularly important as you get a little bit older, over age 50, 60, and also should be complemented by strengthening exercises. Gone are the days when cardiologists only recommend cardiovascular fitness exercises, especially since we recognize that you lose muscle mass as you age. And that natural loss in muscle mass can be attenuated fully by simply strengthening exercises. So we're talking about lifting weights. You should be doing that 2 to 3 days a week in addition to the moderate or intense physical activity that you engage on the cardiovascular fitness end. It's the two together, I think, that are important to provide the most amount of health, especially as you get older and tend to lose muscle mass. Loss of muscle mass or sarcopenia is related to falls, injury, early death, and other complications. So you really want to maintain your fitness level, but you also want to maintain your muscle mass. Excuse me. Obesity. There is on the right. There's a graph that relates your body mass index, which is basically your weight in kilograms divided by your height in the square of your height. So meters squared on the denominator. And there are clear-cut levels that help us understand to what extent we're overweight. A normal body mass index is basically 25 or less kilograms per meter squared. Being slightly overweight is 25 to 29, and above 30 and above is the definition of obesity. Now, it's not as simple as that. We have to recognize that, number one, I don't think that these numbers have been adequately adjusted for African American and African Canadian or African diaspora patients. It's interesting, but these numbers may be slightly different because we tend to carry a little bit more muscle mass, which is very dense. But the bottom line is, since we are more prone to diabetes and more prone to cardiovascular disease, I think we still should adhere to these sort of recommendations to maintain our level of weight in these ranges in order to maintain our maximum, our best health. So another thing is distribution of your fat is important. There is something called centripetal versus non-centripetal fat. If you do a CT scan of your abdomen, you can see how much fat there is in between your organs and your abdominal organs. That centripetal body weight, an easy surrogate is basically your waistline, is an extremely strong predictor of, excuse me one second. Sorry, I had some background noise, is an extremely strong predictor of cardiovascular risk. So it's not only how overweight you are, but it's the distribution of your body weight that's really fascinating. So patients who distribute their body weight, their fat sort of equally up and down, are at lower risk than individuals who distribute their body fat centripetally, which means they get it all in their waistline. In fact, your waistline is an independent predictor of cardiovascular disease and heart attack, which is fascinating. So lots more we could delve in there. I'm not an obesity expert, but some fascinating data that relates to the relationship between body weight and risk of cardiovascular disease. Diabetes mellitus. Diabetes can be, most of the diabetes we see as adults is called type 2 diabetes. It's more of an issue of insulin resistance at the cellular level than lack of insulin production. In fact, type 2 diabetics have high insulin levels, but their tissues are just less sensitive to insulin. That is tracked, unfortunately, with obesity, and there is a syndrome that of being overweight, having type 2 diabetes mellitus, having high triglycerides, and often having cardiovascular disease that clusters together. And so you can reduce your risk of developing diabetes as an adult by keeping good control of your weight, your diet, exercising, and doing all the things that we talked about that are so important to reduce your risk of cardiovascular disease. Now, unfortunately, genetics also play a role here. So many patients, despite their best efforts, will become diabetic and even have type 2 diabetes mellitus. But if you're diabetic and you still control these risk factors, you're much less likely, in particular, to develop some of the microvascular complications, things like eye disease, premature blindness, and of course, what we call macrovascular disease, which is plaque in larger vessels, such as heart attack. The diabetes mellitus, very important risk factor for cardiovascular disease, preventable to some extent, but some genetic overlay as well here that in some cases one cannot avoid. I wanted to talk about aspirin a little bit because the debate has really been contentious over the last decade with regards to aspirin therapy. It used to be that, you know, when I was going through medical school, I came out and I was convinced that everyone should be on an aspirin above age 50. And many care providers were making that recommendation. In fact, the U.S. Preventive Services Task Force had recommended aspirin decades ago, and up until about 10 years ago, that was the case. Now what we're seeing is, although aspirin on the left side of this screen in blue can be effective in reducing the risk of heart attack, stroke, and other vascular diseases, it comes with some small risks. In particular, patients who have peptic ulcer disease, there's an increased risk of gastrointestinal hemorrhage and a slightly increased risk of intracranial hemorrhage as well, bleeding into the brain. So I would just say to you, you know, if you're not sure about whether you should be on aspirin as a primary preventive measure, that is, without any evidence of heart disease, ask your primary care provider. It depends on risk. And if you're low risk, especially if you're low risk and you have problems with your gastrointestinal system, you've had an ulcer, you have gastroesophageal reflux disease, just be careful about ubiquitously taking aspirin. It's not necessarily indicated. Now, the other side of the coin is if you have had a heart attack, or you have had a stroke, or you've had bypass surgery or a coronary stent, aspirin is a pillar in terms of secondary prevention. So it's particularly effective in patients who have established heart disease. So I don't want to get anyone on the line thinking that they should come off aspirin if it was prescribed because they are already showing signs of heart disease, or they've had a heart attack or a stroke, you absolutely should be on aspirin. I'm talking about a healthy 55, 60-year-old person who's at low risk of cardiovascular disease, whose risk score is favorable, and particularly who might have some GI problems. Don't just take aspirin daily. We used to recommend it. It's no longer the case. That's a question for you and your healthcare provider to go over. So right now, the U.S. Preventive Services does not recommend aspirin routinely for those over age 60. That's a change in the recommendation, but to be considered according to cardiovascular risk in those who have a higher cardiovascular risk or who already have heart disease, stroke, coronary stents, bypass surgery, et cetera. Teeny bit about diagnostic testing. I want to spend just a little bit talking about coronary calcium scoring. This is really fascinating information that's come out in the last 10 years. You can get basically a quick picture of whether or not you're starting to develop plaque in your vessels through something called a coronary calcium score. To get a coronary calcium score, this is a very simple test. It takes seconds to do, and it just requires that you sit or you lay under a CT scanner for a very short period of time. It does not require contrast, although the image that I showed is a coronary CT angiogram that did include injection of contrast to look at the vessels. But we don't even need to look at your vessels to know if you're starting to form plaque in the vessels of the heart. And this is one way of detecting asymptomatic cardiovascular disease. Why is this important and when should it be done? It's not necessarily important for folks who are already in a low risk category. If you look at your cardiovascular risk and you're less than 5% risk of having a heart attack or a stroke in the next decade, you're low enough risk that I don't think that a coronary calcium score necessarily helps you. Where it's really valuable are in those intermediate risk cohorts, patients who are between 5 to 20%, who are not already on a statin agent, a cholesterol reducing agent. Let's say your cholesterol is borderline. You don't really want to go on a lifetime medication. You really want to do the right thing, but you're not convinced that on top of your healthy diet that you really should be on a cholesterol reducing agent to lower your risk. And your risk maybe is 10, 15%. Get a calcium score. Unfortunately, this is not covered in all health plans, and I don't think north of the border it's covered by the national health, by the provincial health systems, but it's usually extremely discounted, and usually for around somewhere between $75 to $100. It's not cheap, but it's not crazy expensive. If you really want to know, you can ask for a coronary calcium score. If you get that score and it's high, a normal calcium score is 0, which is just basically measuring how much calcium deposition is there in your heart arteries. Calcium sticks to plaque. Plaque is slightly negatively charged, and over time, if you have a cholesterol plaque in your blood vessels, it almost always gets calcified to some extent. Now, there's a lot of variability from patient to patient in terms of how much calcium deposits occur, and it's not a perfect relationship, but it's a nice, simple screening test. If your calcium score is 0 and you're in an intermediate risk group, you might be a little bit more confident that maybe you don't need that statin, perhaps, or maybe you can just follow that over time and maybe repeat a calcium score in 5 years. If your calcium score is in the hundreds or thousands, you actually have atherosclerosis by definition. And that's useful information because most of these patients won't have any symptoms. Sometimes the first symptoms of atherosclerosis is a heart attack or sudden cardiac death. So if you're not on a statin or an aggressive risk factor profile reducing program, and your calcium score is high, you really need to take it seriously. You, by definition, have heart disease, and you probably should be treated similar to a patient who has heart disease. So lots of emerging data on calcium scoring. I'm happy to entertain further questions in the discussion section, but it's a really interesting, simple test that does not require contrast, and it's very easy to do, but is not yet a routine part of our screening for heart disease. Patients have to ask for it, but if you're in that intermediate risk, it might be helpful. Maybe not so helpful if you already are in high risk and you're already on statin and you're already doing the other things that you should be doing. It's probably not going to change anything, but in some cases it can be quite revealing. There are other diagnostic tests that are done. On the left panel is an example of an echocardiogram. We can now get 3D images of the heart beating, the valves opening and closing. So we can see areas of damage in the heart. And on the right side is the cardiac MR. This is also a still frame, but there are also video forms of this where you can see all the blood entering the heart and contracting. Look at the resolution that we get on these imaging studies. It's really quite remarkable. They're almost like anatomic specimens. So there's lots of other diagnostic testing beyond an EKG, a chest X-ray. Probably one of the most useful things in terms of valvular disease is just the use of a stethoscope. An auscultation of the heart, unfortunately, is a dying talent. When I was training, we were grilled on it. Sometimes I feel that physicians use it as a necktie or a sort of a simple piece that they used for more for show than for utility. But simply listening to the heart can often detect heart murmurs and signs of valvular heart disease as well. So an underutilized, simple, and cost-effective tool that we probably should be using better and more. What are the treatment options for cardiovascular disease? Well, if you develop blockages in your heart arteries, there are various ways. Not all blockages need to be treated. Some are just treated with medical therapy, including in cases aspirin and cholesterol-reducing agents and agents to control angina or chest discomfort. But some patients need the plumbing bypassed, and bypass surgery can be performed. Coronary stenting or stenting of the leg arteries can be performed. We can do vascular surgical procedures. There's replacement of valves that can now be done through catheter-based procedures. Of course, there's a whole host of rhythm disturbances that can be cured in many cases with an ablation procedure, and of course, pacemaker implantation and many others. So cardiovascular medicine in 2024 is extremely complex, but it's gotten much, much less invasive. And in many cases, we can control or even fix cardiac conditions without invading the body in terms of open heart surgery with much less invasive catheter-based techniques. This is just an example of what a heart catheterization looked like. I just took these pictures from our lab recently. Patient's head is on the left, they're draped, and we want to get back to the heart. Well, we can do that by simply accessing their wrist. This is the wrist area that's draped sterilely and prepped sterilely and draped. We can insert a tiny needle into that wrist artery, thread a wire through that. Over the wire, we can insert a catheter, a small tube, and then instantly we can advance the tube back to the heart, inject some contrast, and get these high-resolution images of the arteries. And with that high-resolution picture, when we're done, we can fix if we have to put stents in. When we're done, this is what the recovery looks like. There's no bed rest. They're sitting up. There's a tiny wristband, a bandage applied, and they're good to go. This is an example of an artery that was blocked off. You can see where the blood flow here has stopped right in the middle part of the artery. And that's from a heart attack, plaque deposition, and blood clot. You can see we're starting to get some blood flow back. And now we ballooned it and restored blood flow back to the heart, critical flow to the heart. Patient's chest pain now is getting better. And then we put a stent in here and restored nice blood carrying capacity to the vessel, and the patient does fine. That was a heart attack victim. This is an example of how we can access the heart and put a new valve in with something called transcatheter aortic valve replacement, which is grossly underappreciated and underperformed in Black patients, probably because of lack of symptom recognition and a lack of diagnostic test workup. But heart valve disease is an important form of valve disease where the valves can become dysfunctional and either narrow or become regurgitant or leaky. And now we can replace those valves with relative impunity with very low risk, about a 1% mortality risk, from simply going in the groin and putting in a brand new valve. So in conclusion, cardiovascular disease is the #1 killer in the world. It's extremely important to recognize your risk of cardiovascular disease. Prevention is the key. Somewhere between 60 to 85% of your future risk of developing a heart attack, stroke, or a serious cardiovascular complication is modifiable. The pillars of prevention include smoking cessation, diet, exercise, weight control, control your blood pressure, cholesterol, and in some cases, medications. especially when your blood pressure or cholesterol is not responding to lifestyle modification. And then, of course, early diagnosis can be facilitated in terms of coronary disease with CT imaging, such as calcium scoring. And then there are, of course, other ancillary diagnostic tests that can be performed that are not routine, but can be recommended by either your primary care provider or your cardiologist. And then the bright news, I want to finish on a note, is we've seen the case fatality rate with heart disease drop precipitously over the last 2 decades, partly because of better prevention, but also partly because of better interventions. And we now can perform really remarkable treatments with minimal invasion of the body and extremely predictable outcomes. So I think if I wanted to sort of finish on any particular note, I'd say that because heart disease is preventable, because it's often a silent killer, it can just show up as a heart attack or sudden cardiac death. Know your numbers, know your risk, and go into your doctor's office armed with the information that you can present. Don't go in with a passive approach. Take your health into your hands. This is what we, in general, don't do in general for heart disease across the world and across the country, but in particular in Black populations. We don't always do this to the best of our abilities, but it's very easy to do. And if your provider does not want to spend the time talking to you about your cardiovascular risk as the number one cause of future, number one or number two cause of your future risk of death and debilitation, then I would argue that you need another provider. There should be shared decision-making. You should be informed, and you should be a part of the process for determining your future health and your future risk of cardiovascular disease. So thanks for your time. It's an honor and a pleasure to present to you this morning. Sorry, I was a little tardy. I was running from Washington, D.C. through traffic back into the Northern Virginia where I live and got home just in time for this. But I'm glad I was able to make it and happy to entertain any questions. And by the way, a special thanks to the Harry Jerome Awards. I got that award as the one of the inaugural awards many years back, and I can tell you it's left an indelible mark on my particular career. It gave me just a sense of confidence that allowed me to step out into the world and really pursue my dreams. And it was one of the first awards, academic awards I got. Luckily, there were others that followed, but it was a really instrumental award. I just want to sort of make a plug for the Harry Jerome Awards and all that they've done to help many of us navigate through our careers in a successful fashion. So thanks so much, Anthony, for inviting me. Thanks to the rest of you for allowing me to spend some time with you, and I'll stay on if there are questions, and I'm looking forward to the other speakers.
Yeah, thank you very much. This is so informative. You know, I'm in awe of what you've done. There are a couple of questions that I'm going to read out, and I'm sure you probably answered some of them in your presentation. The first one is, how will someone know when there is buildup of plaque in the heart?
Yeah, it's a very good question. So unfortunately, when you have mild degrees of buildup of plaque, you generally don't notice it, you don't know it. And one of the challenges that all of us face in the arena of cardiovascular prevention is we don't know that that's happening until it's often too late. Now, luckily, many patients will present with angina, which is usually a discomfort, a pressure or heaviness in their chest. It can be in your neck, jaw, shoulders, back, or upper chest. When they exert, and then when you do physical activities, you get this squeezing or heaviness and it goes away. That is called angina. That's how a lot of patients present with blockages in their arteries. The problem with that is when you have angina, and it's from coronary disease, it's usually because there's extreme blockage. Usually the blockage by that time is 80, 90% blocked. But picking it up when you have blockage less than 70% or 50%, it usually doesn't cause symptoms. So the only way to pick that up usually is with that CT scan, to be honest with you. Now, you can get a sense for what your risk is, and your risk is a nice surrogate for understanding, extent of blockage, because that risk predictor predicts your risk of having an event. So even if you have mild plaque in your vessels and your risk is controlled, you're doing the right thing. So you don't need to know every little bit of plaque that you have in your arteries, But if you're curious and you want to know, especially if you're in an intermediate or high-risk cohort, you can ask for a CT calcium score, and that will provide some simple information in terms of whether or not you're starting to develop that plaque deposition.
Yep, thank you. So the next one is, what is the difference between a heart attack and cardiac arrest?
Yeah, that's a good question. Heart attack is damage to the heart muscle that usually results from a blocked artery, usually a sudden stoppage in blood flow to the heart muscle. That causes what we call myocardial necrosis or cellular death of the actual muscle. Once that muscle's dead, unfortunately, it doesn't really regenerate very well. And so you're usually left with a scar and a damaged heart that can expose you to heart failure and other problems, rhythm disturbances. That's not the same as ventricular fibrillation or sudden cardiac death. Cardiac arrest is basically when your heart stops completely. Many causes of cardiac arrest are related to heart attacks. So when your heart suddenly develops a blockage with a blood clot that stops the blood flowing down one of the arteries and causes heart damage, the heart attack, sometimes your heart stops in that process. The sudden stoppage is called cardiac arrest. Cardiac arrest can also be caused by other factors, diseases of the valves or heart muscle, in particular hypertrophic cardiomyopathy, and in some cases where athletes are struck just at the wrong time, such as the recent NFL player had the cardiac arrest. That can also hit in the chest just at the wrong time can also cause cardiac arrest. So there are multiple causes of cardiac arrest, one of which is a heart attack.
Right. The next one is, do Fitbits accurately measure blood pressure? In fact, what about wearables? Do they measure accurate?
Yeah, so huge market for wearables. I think there are some really kind of neat and cool technologies. There are early adopters of the wearables, and there are others who kind of are the last to catch on. I can tell you that so far, this is a huge market, so there's a lot to be sold and a lot to be profited from. You have to be a little bit careful about what you read and what you think is helping you. I can tell you the following. Number one, wearables are going to become more common and more implicated into how physicians treat and follow you. However, current guidelines do not really account for wearables much. A simple ambulatory blood pressure reading, which is a cuff that goes on the upper arm, not on the wrist, is the best way to measure your blood pressure at home. There are no wearables yet that are, there's some wearable technologies that can translate that information on the cuff into a storage system that's easy to get access to later. The one wearable that I would say, I don't have Apple stock, other than in mutual funds, but I can tell you that the Apple folks, they've done a terrific job with their algorithm for atrial fibrillation. That is about 99% accurate. So I would say that if you have an Apple Watch and you have questions about whether or not you're having a rhythm disturbance called atrial fibrillation, you can actually get a good EKG reading from that. There are other wearables that can give you EKG readings. I'm not trying to plug one over the other. It's just trying to figure out how to use that information beyond just emptying your wallet in terms of the cost for buying it and then purchasing any surveillance plans. So far, they've not become a routine part of practice, but I would predict in the next 10 to 20 years, we're going to get a lot more information and try to connect the dots between the wearable data and actual outcomes data, which has been lacking so far.
Thanks. The next one is, when should diagnostic testing, example, ECG, MRI, be done?
Yeah,
would it be helpful if it's just concerned about HBP?
Yes, I think if you have high blood pressure, and EKG can provide a lot of information. It doesn't have to be done every time you're in the doctor's office, but if you have cardiovascular disease or you're at risk, an EKG is typically done on an annual visit. And then if there's a change in symptoms, you're developing chest discomfort, shortness of breath, often an EKG is a very inexpensive way of seeing if there's any major change. Or if you're having rapid heart pounding or blacking out spells, an EKG or a cardiac monitor is very helpful. Beyond that, diagnostic imaging such as echocardiography, MR, CT scanning is usually only indicated for abnormal test results, maybe an abnormal EKG or if you're having symptoms that warrant it. We don't do it routinely for screening purposes. For example, echocardiography, CT scanning, and MR is not done as a routine screening part of your exam. Now, but if you have symptoms, these tests are very important. Or if you have abnormalities that your doctor's concerned about based on your physical exam, a heart murmur, or your EKG or other factors.
So this next question, how best can we educate ourselves to challenge our primary health care provider about our numbers?
Well, I would go in, I would, go in, hopefully folks have, and you can distribute, I'd be happy to give you my slides when we're finished. You can go to that website that has the AHA cardiovascular risk calculator. Go in and ask your provider, are you familiar with this or any other risk calculator? There's some other ones, but this is the most popular and well-validated tool. And then say, hey, this is what I got on my numbers. And for that, you have to have your cholesterol, your blood pressure, age, sex, and it's a very simple calculator beyond that. And if you go into your primary care physician or provider's office with your numbers, I'm telling you, it changes the conversation. Now that provider is put in the position of having to face the reality of your risk and having that conversation. And that also saves a lot of time because they don't have to calculate it. You've already done it. It does take a little bit of time. So you've already saved that doctor maybe 5 or 10 minutes to do that calculation, him or herself. And that's time that could be spent on talking about what to do about it. What in your particular case you need to consider for risk reduction.
Right. Right. There's a question that came in from the text messages. What is cardiomyopia and is it hereditary? This person was diagnosed at 45. His mother died from heart attack and one brother and 2 sons have the same condition.
Yeah. So there are cardiomyopathies that are genetically determined and others that are not. So most cardiomyopathy has only a weak link to genetics. And that's what we call dilated cardiomyopathy. There are some familial cases of dilated cardiomyopathy where the heart enlarges over time and the heart muscle becomes weak. That's one form of cardiomyopathy. Most of that is not genetic, but there are some real strong familial cases of that condition. The other form of cardiomyopathy is abnormal heart muscle thickening. And I would be concerned about in this case that you present whether or not this family has hypertrophic cardiomyopathy. That is an abnormal thickening of the heart muscle where it gets thicker and it starts to obstruct outflow in some cases or cause serious rhythm disturbances. Hypertrophic cardiomyopathy is inherited in an autosomal dominant fashion. So that means that if one of your parents has hypertrophic cardiomyopathy, you have a 50% chance of inheriting that. So we see that more prevalent in families, and you can see how it's passed down from generation to generation. So I would question whether or not in that example, the patient has hypertrophic cardiomyopathy. That can be also tested for with genetic testing. There are probably 80 or 90 mutations that have been identified, largely related to something called the myosin protein. That's something that you can ask your doctor about if you think that there could be a familial tendency. If you're diagnosed with hypertrophic cardiomyopathy, you should have your family, your first-degree relatives screened, either with an echo or with genetic testing. Very important.
Okay. Charles, do you have a question?
Yes. Thanks, Dr. Batchelor, for an informative presentation. The question I have is, what role do you see AI playing in heart health?
Terrific question. Absolutely love this question. AI, as you know, as everybody on this call knows, is just like a firestorm right now, taking over many of our conversations and certainly having an impact on almost every aspect of what a business and health and finance and everything else that we do. So I think it's fascinating. I'm actually doing a randomized trial right now in the United States, deploying AI in several different health institutions, systems. Millions upon millions of patients will have access to. And we're trying to test if recognition using AI platforms of heart disease can be amplified using a simple AI tool. There's just phenomenal information that you can get from simply gleaning health records. it's virtually impossible for any primary care provider to really go into any degree of detail with the information in your record. Remember, you've got digitized information from chest X-rays, from EKGs, from echocardiograms, and right now we can go in there with AI, glean all of that information, and put it in a black box model and understand if you have heart disease. It's pretty easy to do. So the question is, how is it deployed? What utility does it have? And we're actually doing a randomized trial prospectively evaluating the incremental diagnostic capability of AI when deployed across multiple health systems. And we're going to randomize providers to get prompts where AI will pop up and say, look, your patient has severe aortic stenosis. They haven't had a valve replacement or been referred. Click this box to start a referral to a cardiologist. If we show that actually empowers and adds incremental value to regular health, then we've got a winner. The downside of AI is it's just a ton of information. We have to know what we want to put into these models. It's sort of garbage in, garbage out. It can provide all sorts of unnecessary and not helpful information. It's got a cost associated with it. And again, it's a business. So everybody in every single company wants to have a piece of this large potential pie. So I think there's going to be value. I can tell you right now that AI is better, is definitely as good or better than a radiologist at reading certain types of X-ray films. So in the radiology and the X-ray reading department, it's extremely important. And I think assisted AI, where you have AI can exclude all of the normals very quickly. If you have a radiologist has 300 chest X-rays to read, AI can go in there and say, these 200 are normal. You don't even have to look at them. It's so accurate. But where it could be probably most valuable is identifying that little tiny breast lesion on the mammogram that's questionable. Algorithms should be able to refine that diagnosis better. Then have a radiologist who's got the experience to interpret that, come in and help out. I'm not trying to put radiology out of business. We need radiologists, but they're going to have to get clever to the point where they understand how to use this as a tool, not as something as a replacement therapy for their business. But it's in radiology, it's absolutely incredible how accurate and how effective AI algorithms are in detecting all sorts of minor abnormalities that sometimes the human eye can't see.
Okay, thank you very much, Dr. Dwayne. This has been excellent.